Gentlemen, it's a pleasure for me to be here in this lovely city of Shimla. After landing here in the morning, me and Dr. Pankaj went for a very nice walk on the mall. We saw all the historical places on the mall. I had been to Shimla a few years back, and this walk on the mall revived my memories. That these are the things which we have seen before 8 or 10 years, and how the things are evaluated. My talk is going to be on progesterone in IUI. Progesterone is most commonly used drug by infertility specialists and gynecologists, and maybe it is one of the most abused drugs. People are giving it left and right without knowing how to give, what is the doses, when to stop, when not to give. Progesterone and the menstrual cycle. We all know post-ovulation, the normal corpus luteum function dependent on the pulsatile LH release from the pituitary. And this corpus luteum is producing both estrogen and progesterone to produce the endometrial changes to facilitate receptivity or implantation. If the fertilization happens after ovulation, the corpus luteum is stimulated by HCG, which is produced by this embryo, and corpus luteum continues to produce progesterone. That is how the progesterone is produced by corpus luteum. And in luteal phase, progesterone is needed for endometrium for implantation. In the follicular phase, progesterone prepares and transfers endometrium to allow for implantation. And in the luteal phase, if the embryo does not implant, the corpus luteum degenerates due to lysis, and the lack of progesterone will result in menstruation. But if the embryo implants, then the embryo will produce HCG along with LH, and it maintains the corpus luteum to produce progesterone. That is the basic thing, that in follicular phase, progesterone is produced, and in luteal phase, the progesterone is produced if the ovulation has happened, if the conception has happened, the HCG produced by the embryo will further stimulate corpus luteum to produce progesterone. And progesterone is essential for embryo implantation and early pregnancy support. Progesterone will support the endometrial growth for successful implantation. It will suppress the uterine contraction, and it modulates the immune response to prevent rejection of embryos. So these are three main functions of progesterone: endometrial changes to secretory endometrium, suppress the uterine contraction, and modulate the immunomodulator. These are again various roles of progesterone have been assigned by different authors, and we have seen a removal of corpus luteum prior to 7 weeks of gestation will lead to pregnancy loss. So that means that we need corpus luteum for till about 7 weeks, so that the corpus luteum will keep on producing progesterone to support the pregnancy. That is one of the important points you have to understand. This corpus luteum is needed for the support of pregnancy till 7 weeks, 7 to 8 weeks. This is the luteal phase in natural cycle. If you look at the luteal phase, there is a peak of progesterone somewhere in the mid-luteal phase. So the most critical phase in both natural and luteal cycle is the mid-luteal phase, where the implantation is anticipated to occur. It is 7 to 10 days after the ovulation in natural cycle, and if we do a lucid retrieval, 2 to 3 days following embryo transfer in a stimulated cycle. That is the time when implantation is supposed to happen. And a mid-luteal progesterone level of more than 10 nanogram is deemed necessary. Approximately 8% of the patient normal ovulatory cases are reported to have luteal phase insufficiency, where the progesterone level is less than 10 nanogram. Despite the lack of clear consensus on the exact limit value, the mid-luteal progesterone value of 13 nanogram for stimulated cycles are suggested to be critical values for clinical pregnancies. We are presenting one paper in this coming IVF conference in Tokyo that is about the progesterone level in the luteal phase, and we have analyzed our results that when the progesterone level is more than 25 nanogram per ml in the mid-luteal phase, there are very high chances of pregnancy to happen and continue. If the progesterone level is between 15 to 25, the pregnancy may continue, and if it is less than 15, that pregnancy may not continue in future. So progesterone level, that is what we have made progesterone level in the mid-luteal phase. Serum progesterone level peak during the window of implantation. And during the follicle phase, high circulating progesterone level identify premature luteinization and endometrial asymptomy. And luteal phase, it is suggested a single progesterone level measurement less than 10 nanogram indicate luteal phase deficiency. Progesterone therefore remains a critical routine treatment success in IVF. Detecting the luteal phase insufficiency, when the serum progesterone is less than 3 nanogram per ml in the mid-cycle, that indicates that ovulation has not happened. Blood level between 2 to 40 nanogram is the broad range. But however, there is no consensus on the minimum serum progesterone concentration that defines the luteal function. We are still not sure what should be the level. Like I mentioned in our study which we are going to present, we have found out the serum level more than 25 nanogram that indicate that pregnancy is likely to continue further. But we are still not having consensus what should be the minimum serum progesterone level. Is the luteal support needed? Yes, fertility treatment interferes with luteal phase via several mechanisms. And whenever we have a stimulated cycle, we need to give a luteal phase support. And in IUI, the debate continues. Whether the IVF cycle needs luteal phase progesterone support or not, the debate continues.